My name is Jenny Best. I'm a pediatric nurse practitioner student at Emory University and the current president of Health Students Taking Action Together Incorporated. So on behalf of our team, I want to welcome you to this event, which we've titled Georgia's Healthcare Provider Shortage, the Interdisciplinary Piece of Access to Care. Just by a show of hands, how many of you is this anyone's first health benefit? Wonderful. Well, an extra special welcome to you. For those who may be less familiar, HealthStat is a student-run nonprofit organization here in Georgia. We're interdisciplinary and statewide, and we have a two-part mission. And the first part is to empower health profession students as leaders and advocates, and the second is to build a healthier Georgia mission and advocacy. And we have long been involved in advocacy as it relates to access to care. But this event tonight is a little bit new and different for us. We've never talked directly about professional issues as they relate to access to care and the practice that we're all involved in or about to go into. So we're thankful that you're all here tonight to engage with us in some meaningful discussion. So this event was really inspired by a recent report published by Georgia Watch, and we have the author, he's right here in the room, which is wonderful. So thank you, Beth, for being here. And that report is called Perspectives on Advanced Practice Registered Nursing in Georgia. And as a future nurse practitioner, I was thrilled to see it, and I think it really outlines some of the challenges that are facing our state with access to care, and of course proposes some solutions. So we'll definitely talk a bit about that. And in that report, we learned that, of course, we've all heard of this national physician shortage, but we learned in this report that Georgia is expected to fare among the worst of states nationwide. Georgia is currently 39th in the nation for the number of physicians per capita, with the most severe shortage affecting primary care, and we're expected to rank last by the year of 2020. Georgia is also 49th in the nation for the number of primary care physicians per capita, with over 80% of Georgia's counties containing substantial populations without a consistent source of primary care. And as a soon-to-be pediatric primary care practitioner, it's extremely concerning to me that 63% of Georgia's counties, which is over a third, do not have a single pediatrician. And we also have very severe shortages in mental health and obstetrics and gynecology, which we'll hear more about. So the Georgia Watch report ultimately advocates for full practice authority for APRNs to alleviate physician shortages and improve healthcare access in Georgia. And the health and adequate access to care exacerbated by these provider shortages is a critical issue in Georgia, one that needs to be addressed collaboratively and with a sense of urgency. As an interdisciplinary organization, we value numerous professions that contribute to advancing the health of people and populations in our state. We also understand that healthcare access is a complex issue, and that we may have questions about how best to tackle these provider shortages and optimize our healthcare team. So it's in that spirit that we welcome you here tonight, and we hope that this will be an informative, candid, and productive discussion on professional issues that impact healthcare access in Georgia. So without further ado, it's my pleasure to introduce our panelists now. And we'll start with physician assistant, Allan Platt. Mr. Platt graduated with a BS in Health Systems Engineering from Georgia Tech in 1977, a BS in Medical Science from Emory University School of Medicine Physician Assistant Program in 1979, and MMSc in Career Physician Assistant from Emory University in 2006. From 1984 to 2004, he was Program Coordinator and Physician Assistant at the Georgia Comprehensive Sickle Cell Center at Grady Health System, the world's first dedicated 24-hour emergency center for sickle cell patients. He is the web designer of the Sickle Cell Information Center and co-author of Hope and Destiny, a patient and parent's guide to sickle cell disease. He also edits a monthly sickle cell newsletter distributed to 4,000 readers worldwide. Allan is also co-author of Overcoming Pain and author of Evidence-Based Medicine for PDA, a Guide for Practice. Mr. Platt is the recipient of the 2002 AAPA Paragon Teacher of the Year Award and 2007 AAPA President's Award. He is currently an academic coordinator and director of admissions at the Emory University School of Medicine Physician Assistant Program. He is the author of the E-Connections feature in the AAPA publication, PA Professional, and was the technology and education feature editor for the Journal of Physician Assistant Education until 2013. He volunteers pre-subbing students at Good Samaritan Health Center and the South Georgia Farm Worker Project. And Mr. Platt currently directs the annual Emory Board Review course in Atlanta, and video edited into a 36-hour home study course for PAs around the globe. Mr. Platt is also the webmaster for Emory PA program at emorypa.org. Please join me in welcoming Mr. Platt. And next we have Ms. Searcy, a pediatric nurse practitioner with over 20 years of experience in clinical practice, health policy, and advocacy with a focus on primary care, child and adolescent injury, substance abuse prevention, and government affairs. She earned her bachelor's degree in nursing from the University of Florida and her master's in child health and pediatric nurse practitioner degree from Emory University in Atlanta. She currently provides hospital-based newborn care with Marietta Neonatology in Marietta, Georgia. Ms. Searcy is currently the chair of the Health Policy Committee of the National Association of Pediatric Nurse Practitioners, NAPNAP, and was recently elected as president-elect of NAPNAP. She is a past president in the Nurse in Washington Internship Program and a member of the American Association of Nurse Practitioners, or AANP. She was selected as the recipient of the 2014 AANP Nurse Practitioner State Award for Excellence from Georgia. Ms. Searcy is the co-founder of the Georgia Coalition of Advanced Practice Registered Nurses and currently serves as the coalition's Health Policy Director and Legislative Liaison. Please join me in welcoming Ms. Searcy. And next up, we have Dr. Hoffman, who began his medical career in family medicine and practice, affiliated with the National Health Service Board in the rural Appalachian Mountains of North Carolina. After several years in private practice, he joined a managed care practice in Atlanta with a large multi-specialty medical group affiliated with Group Care HMO. Dr. Hoffman then transitioned to medical administration, holding medical director positions with MetLife, Metro Health, Blue Cross Blue Shield of Georgia, and WellPoint. While at WellPoint, he held several positions with responsibilities covering WellPoint's disease management and wellness programs and national account medical management. He currently has a consulting practice in Atlanta. Dr. Hoffman is a magna cum laude graduate of Duke University and received his medical degree from George Washington University. He completed his residency in family medicine at the Mountain Area Health Education Center in Asheville, North Carolina. Dr. Hoffman is a member of the American Association of Physician Leadership and continues to be active with the American Academy of Family Physicians. He is currently serving as president of the Georgia Academy of Family Physicians. The GAFP is Georgia's largest primary care organization and is leading the way to transition practices to patient-centered medical home model of care. Please join me in welcoming Dr. Hoffman. Next, we have Senator Chuck Hufstetler of Rome, Georgia. Senator Hufstetler has represented Senate District 52 since being elected in 2012. He is an anesthesia provider at Redmond Hospital in Rome. He previously served on the Floyd County Commission from 1998 to 2006 and also served on the Floyd Hospital Management Board for 8 years. In the Senate, he is Chair of Retirement, Chair of Appropriations for Criminal Justice, Vice Chair of Health and Human Services, and a member of the Education Committee. Recent awards include Georgia Budget Policy Institute Legislature Leadership Award for his principled stand in favor of Medicaid expansion. Georgia Watch also honored him last year as one of its 4 consumer champions for his work on access to healthcare. And Creative Loafing just awarded him with a He Who Speaks the Truth award, saying he doesn't let politics influence his decisions. He is also a member of the Georgia Integrated Health Committee, sponsored by the Carter Center, and an adjunct professor at the Emory University School of Medicine. Welcome, Senator Hufstetler. And last but not least, we have Dr. Adrienne Zertucci and Ms. Meredith Pinto. Dr. Zertucci is a resident physician at the Emory Department of Obstetrics and Gynecology and a founder and board member of the Georgia Maternal and Infant Health Research Group. She is also an APARN Georgia Section Junior Fellow Vice Chair. Ms. Pinto is a recent graduate of Emory University Raleigh School of Public Health who is currently working with the CDC in the Division of Emergency Operations in the Ebola response. And the Georgia Maternal and Infant Health Research Group is an interdisciplinary team of students and professionals supported by the OBGYN Society, Department of Public Health, and March of Dimes. GMERC has been instrumental in studying and drawing attention to Georgia's severe OBGYN shortage, as well as advocating for maternal and child health initiatives statewide. So again, another big welcome for all of our panelists. So we'll go ahead now and begin our discussion. I'm going to start with a few questions for our panelists, and then we'll open it up to the audience. So we hope that you all will participate and engage in this dialogue with us. So I'd like to start with Mr. Platt, Ms. Searcy, and Dr. Hoffman. And our first question for you is, from your profession's perspective, what factors or barriers are contributing most to Georgia's provider shortages, particularly in rural primary care? And what solutions would you propose to address these issues and improve healthcare access in Georgia?
First, okay. One, I think the best way to recruit people is to have people from those areas come to school and go back. So recruiting the caliber of people to come and to put up with the funds of Emory and paying for that and not having loan reimbursement and all of that, you know, that's a barrier. I think the next way would be to have rotations, and we do have rural rotations for our students. You have to go outside of Metro Atlanta and go rural for at least 2 or 3. But to have the people do rotations there would attract them to work there. I know that's how I attracted my best staff to Gritty. Had no benefits, no anything, bad hours. Why would you want to work there? But when we had students rotate with us and saw that we could do a marvelous job together, they stayed. And they would put up with the bad hours and the low pay because it was a great job. So I think in rural areas, if you can get students there to practice as, you know, in part of their training, they'll go back. Having loan forgiveness would be an awesome thing too. I know National Health Service Corps has limited funds, but there really were state funds to say, you know, you come work here for a year and we'll take a year of your debt. That would be a high incentive. So those are all things I see as some barriers that doesn't fix this.
Good evening. I want to focus a little bit more on our worsening physician shortage and where Georgia is in utilizing its non-physician workforce. As you've heard, we're 49th in the country in primary care physician supply. That's worsening over the last few years, and our population is one of the fastest growing in the United States. More folks are accessing insurance and coverage, so there's a great deal of demand. The other issue that we have in Georgia is chronic illness is eating our lunch, budget-wise and quality of life-wise. We have some of the highest burden of tobacco-related illness, diabetes, cardiovascular disease. And then you add into that our providers are not evenly distributed, leading to the extreme lack of access to care that we see, especially in some areas like OB care, pediatric care, primary care, and some of our rural communities. And we still have a statutory and regulatory environment that matches 1970s medicine. Georgia has not updated its laws, its rules, and administrative policy to be in line with current evidence and the experience of other states. And these laws and regulations were imposed with all good intentions. And those good intentions were to provide protection that Georgia residents would be getting their health care from qualified providers. But as I said, they've failed to keep up with how our healthcare professions are evolved and how our supply has evolved, and it's negatively affecting both quality and cost. So bringing Georgia's laws and regulations in line with recommendations from a variety of expert panels would increase access to quality healthcare, improve healthcare outcomes, improve the efficiency of our healthcare delivery system, and reduce costs. And these types of changes have been recommended by bodies no less than the National Governors Association for Best Practices, the American Hospital Association, the Institute of Medicine Report on the Future of Nursing, the conference proceedings of the Georgia Josiah Macy Foundation, the Federal Trade Commission, and a collaborative effort of the Rural Health Research Center, and on and on and on. So the evidence is there that we need to look at ways that we can update how we provide access to our entire healthcare provider workforce in Georgia so we can better meet the care of our citizens. And there's a variety of ways. I don't have all the answers to how to do that, but it involves the collaborative efforts of everybody, understanding that all professions have a role to play, and we need to step back and work together and look at what we can do to get all hands on deck, helping meet the extreme needs we have from the state.
Thank you for having me. This is a real honor to be here. This is something that is near and dear to my heart in terms of dealing with primary care physician shortages. One of the things that I just attended an area health education center primary care summit last week, and I learned some things there. We always assume that debt, medical school debt, and salary, especially in primary care, is the main reason physicians decide not to go into primary care medicine. Interestingly enough, when the Georgia Board of Physician Workforce surveyed people about 2 or 3 years ago, graduating residents, when they pick their specialty and where they go for their graduate medical education, the number one reason was lifestyle, not debt. That didn't even make it into the top 3. The others were having a mentor, preceptorship. To Alan's point about having the availability of access to a rural rotation, I think is critical in getting people to realize what that's like. But I think lifestyle for me, I'm a good example of what happens with the National Health Service Corps. It got me to a rural area, and I stayed longer than I had to, but lifestyle was an issue. It was, every other night call, and having to drive 20 miles to the hospital, and 20 miles to the closest movie theater. Schools, things like that, those are big issues. So I think we need to address that as well. And the third thing that was important to some of our graduating residents, or graduating medical students, was the availability of a fellowship at their residency. Now, to me, that says a lot of medical students that are going into primary care specialties are not staying in primary care. Internal medicine, for example, they go on to further subspecialize, not so much in family medicine. But still, many of them go in, and so even though we may be kidding ourselves thinking that more and more medical students are going into primary care, they often don't stay there. So I think we need to increase the number of graduate medical education slots, and the state legislature did that 2 years ago. They added 400 graduate medical education slots in primary care specifically. That's not up to speed yet, but even adding those 400 only gets us to the Southeastern average for number of graduate education slots per capita. So we've got a long ways to go. I think we firmly believe as a specialty in family medicine that nurse practitioners and PAs are a critical part of the team. I'm a little concerned about changing all of our regulations without doing other things. For example, right now, of the nurse practitioners in Georgia, 76% of them practice in specialties, not in primary care. So I'm a little concerned about prematurely changing a lot of our regulations until we address the fact that how do we get nurse practitioners and physician assistants to also go into primary care and to not practice in urban areas. 76% of the nurse practitioners practice in an urban area, not in a rural area. So we have the same problem with mid-level or advanced practice nurse practitioners as well as PAs that we do with primary care physicians. Is that getting them to practice in a rural area, we need to address things like lifestyle, we need to address things like getting people there for their preceptorships and rotations so they understand what it's like, and put down some roots. And I think we'll get people to stay there. And Alan also mentioned, we agree with this completely, that identifying people from those areas and helping them get into medical school and helping them get into residency. We have a Pathways to Medicine now that's part of the AHEC organization, and we have one in Albany, and they're going to start one in Gainesville this year, where they identify people who are candidates for medicine early on, because those are the people that are going to want to go back and put down roots in where they grew up.
And Ms. Searcy or Mr. Platt, if you can speak to nurse practitioner or physician assistant specific barriers, and perhaps share your thoughts on full practice authority or removing some of those barriers to address provider shortages.
I mean, the PA concept is that PAs work under the supervision of a physician, so they work as partners, as a team. And so really that's established. The PA is basically most facile because they can change from one specialty to another without being boarded or retrained. So they can move into an area where they're needed and then change specialty to another area they're needed. You could have 4 or 5 careers in a 40-year span. So they're perfectly mobile. They can go where they're needed, and they can change based on, and it's a preceptor model. They get on-the-job training with a physician who basically mentors them to be what they want them to be, to do what they want them to do. So it's kind of like old-time medicine back in the 1900s. That's the model, and it's working very well. So the barriers are there. It's just getting the physicians out into the rural areas to, again, hire work PAs, mentor them, and basically turn them loose. And I think that would be a way to make this work.
There are some specific barriers that I think that address this really, and I think what we need to do is put this in perspective about not getting involved in interprofessional turf wars. We all collaborate together. We all work together. Medicine at any level is a collaborative practice. Whether your collaborator is next door to you, whether your collaborator is 2 counties away, and whether or not you have formal contractual requirements for collaboration, we all collaborate. We all see our patients. We all have our colleagues that we talk about. If we have difficult patients, we all refer to other providers, other specialists, other disciplines, if the care of our patients demands that. In Georgia, there are some specific barriers to advanced practice nursing practice that do not exist in other states, that do interfere and stop care. And those are barriers that require whenever a physician's physical signature is required before care can proceed. An example of that is in the 2006 law that granted APRN's prescriptive authority, and we were the last state in the country to do that. There was a requirement put in that MRI, CT scans, nuclear medicine scans would have to have a physician's signature to be ordered, unless it was a life-threatening emergency. Well, back in 2006, digital mammograms were just coming online. Nuclear cardiology scans as the follow-up of standard of care for an abnormal EKG was just a small part of practice. So as our diagnostic capabilities have evolved, there is a whole cornucopia now of very common, very necessary exams that can't be ordered by an advanced practice nurse until a physician's signature is obtained. Now, in the metro Atlanta area, that's not such a big deal because most of us work on site with the physician. But in our outlying rural areas, and even in some of our unserved areas in the metro areas where there is not a physician on site, there's a need to be faxing, et cetera, and going through, and it delays care, adds to the cost of care, and interferes with treatment being started at an exact time. And an example of that would be, I'm familiar with an advanced practice friend of mine in rural Georgia who had a woman come into her practice who was a breast cancer survivor who had found a lump and needed diagnostic digital mammogram. And it was a Friday afternoon. Her collaborating physician, who was in another county, was gone for the weekend. And a signature to order that mammogram could not be obtained until the next Monday and get her scheduled the next Tuesday. And it ended up she did have a recurrence of her breast cancer. And that is an unnecessary delay of care, a cruel anxiety for a patient to have to wait that long, where there's no standard of care training or quality of care reasons why advanced practitioners can go ahead and do that. We have some other issues with our ability to prescribe common medications, including Schedule II medications. Now, we're all concerned about diversion and opioid overprescribing and opioid addiction. But Schedule II medications go far beyond oxycodone and their derivatives. We have nurse practitioners now that since 2005 have been certified in both primary care and acute care. And acute care nurse practitioners are a beautiful example of a collaborative team. While the neurosurgeon is in the operating room doing what the neurosurgeon's trained to do, the advanced practice nurse who's acute care trained is on the floor doing rounds, doing discharge management, running clinic. And when discharges are held up because that advanced practice nurse now can't prescribe 5 days of Lortab for post-op pain, again, that's not efficient care. That's not full utilization of all of the skills of all our patients. And there are others. And these are just some examples of things that there are now a mismatch between the availability of physician supply and the availability and where advanced practice nurses practice. And we just need to figure out a way to eliminate barriers to care proceeding that aren't backed up by evidence. And I'd like to disagree a little bit, respectfully, with Dr. Hoffman. This is a map of just nurse, now advanced practice nurses, there are 4 categories of advanced practice nurses. There are nurse anesthetists, certified nurse midwives, clinical nurse specialists, and nurse practitioners. Nurse practitioners are by far the largest category. There are 77,000 nurse practitioners currently licensed in Georgia. And this is a map that I obtained from the American Association of Nurse Practitioners just recently that shows the distribution of practicing nurse practitioners in Georgia. And you can see the darker the area on the map, that's the larger number. And this is by congressional district. The darkest is over greater than 500 nurse practitioners. The 400 to 499, 300 to 399. So we do have quite a supply of advanced practice nurses practicing in rural communities who could provide more efficient, more effective access to care if practice laws were modernized in Georgia. And on our national data shows that more than 2/3 of nurse practitioners practicing at least one primary care site. Sometimes I think there's confusion. Our education model is very different from the PA's education model in that when we go back to our graduate programs, we specialize in an area of population focus. But a lot of the, like either family, adult gerontology, pediatrics, neonatal, women's health, psych mental health. So while our graduate education is specialized in population focus, most of us practice in primary care, at least in part of our careers, with the exception of our acute care advanced practice nurses. So I'll finish with that, but thank you.
Thank you.
Yeah. I think I don't disagree with much of what you said. I think that I would like to see, though, a distribution of nurse practitioners in those congressional districts, because it's possible by looking at that map that all of them could be in Macon, and still, because the way you're doing it by congressional district, I want to know how many are in Valdosta. Yeah, I want to, because that's what the issue is, not how many are in the total congressional district. I also have some issue. We are sensitive as a profession to the issues that you outlined about discharge planning and being able to get your Schedule IIs. As you also mentioned, we have a big problem with prescription drug abuse in the state. And one of the things that I'm concerned about is we need to have some controls in place before we remove and increase the number of people who can write for Schedule IIs. I will be the first one to state that we have a big problem with physicians over-prescribing Schedule IIs and prescribing quantities too great for the need. So I think it would be mistaken for us to remove the controls that we have right now and increase the number of prescribers. Part of my other career has been to work as a medical director. I also know that we have a tremendous problem of overutilization of unnecessary diagnostic testing. And we need to, I'll be the first to admit that I've had to counsel many of my physician colleagues, and we're working as an organization to order smartly in terms of diagnostic testing. So again, to remove the controls that we have and allow total independent practice without some control of that, without other requirements in place first, is concerning to me that we will have unintended consequences of higher unnecessary utilization and higher prescribing of Schedule II dangerous drugs.
Thank you. Next, I'd like to invite Dr. Bertucci and Ms. Pinto to share a little bit about their work. What I'm curious about is what you've learned from your research on Georgia's OBGYN shortage, and how might your findings apply to and direct solutions for Georgia's provider shortages across health fields?
Again, thanks, just like everyone else had already mentioned, thanks for having us here tonight. Wow. The Georgia Maternal and Health Research Group has been around for about 5 years, and we've been doing research over that whole time. Our initial study was done back in 2011, and that was kind of our defining study because what she was alluding to was we defined this problem specifically. Everyone's aware of the shortage nationwide in rural areas, any type of provider, but specifically for maternal and infant health, looking at obstetric providers or delivery providers. In rural Georgia, we, specifically outside of metropolitan Atlanta, we had discovered at 2011 that over half of what we call primary care service areas, which are collections of counties where most people get their primary care, over half of those areas had an insufficient number or a complete lack of delivery providers. And based on some sustainability questions that we also asked of the survey, we estimated that that number would increase to about 75% by 2020, which is just shocking. We made this map similar to the map that you have, a green map, which maybe some of you have seen, that kind of demonstrated the distributions. So thinking not only about an overall shortage, but where are the areas that specifically have a complete lack of providers or are very at risk because they only have 2 providers and one retires, then the whole system will cave in. And then based on that initial study, we kind of launched a whole number of other studies to look at what are some reasons that this is happening, and what are, based on that, what are some consequences that are resulting, and then taking it another step further, what are some potential solutions? I'm not sure where to go. We've got so many different things we've done. So I guess some things that people had alluded to before, definitely thinking about it from a provider perspective. So we did a survey of both resident OBGYNs in Georgia, as well as certified nurse midwifery students in Georgia. And we asked a slew of questions, but the thread that was really common, both amongst the residents and amongst the certified nurse midwives, was people with a tie to Georgia, whether they had, whatever type of schooling they had done in Georgia in the past, were more likely to consider staying in Georgia upon graduation. And then in order to attract people specifically to these non-metropolitan areas, financial incentives were where the money was, literally. Offering things like loan repayment or differential pay or guaranteed salary. There was a huge shift. I can't remember the numbers exactly, but I think anywhere from 22% of residents were likely or extremely likely to consider working in a short area. When you add some sort of financial incentive, it goes up to like 60 or 70%. So for instance, based on that particular study, that thought, well, how can we apply this? And the Georgia Board for Physician Workforce has a program in place that permits loan repayment for particular providers that work in counties of less than 35,000 constituents. The issue with that is that if you think about the counties that actually have labor and delivery units, and thereby have the capacity to deliver obstetric patients, those are not typically in the counties that only have 35,000 or less people. They might be in the neighboring county that has closer to 50,000, 100,000 people. So a lot of the residents that were graduating were not candidates for this loan repayment program, because even if they were interested in going to a rural area to have their loan repaid, they could not find an open labor and delivery unit with a surrounding OBGYN practice that would be a viable option for them to pursue as a career. So one of the things that our group did was work with the Georgia Board of Physician Workforce and the Georgia OBGYN Society on making an amendment via a bill of the Georgia General Assembly in 2013, I believe, that just amended the criteria and said that the Georgia Board for Physician Workforce actually has the capacity to decide where people can go to work in order to qualify for the loan repayment program. Do you want to talk about the certified nurse midwifery and all that stuff?
Yeah, so basically, also, thank you so much. So one of the other parts of this big research project that Adrian was just talking about is that
we had the opportunity to also talk to a variety of providers and people that work in the service delivery sector. So we talked to OBGYNs, we talked to certified nurse midwives, we talked to people that work for care management organizations that distribute Medicaid. We talked to people at the Department of Public Health, and so we got a variety of interviews and a wealth of knowledge on the different types of barriers that they faced when trying to provide care, and also different ideas for the solutions that they might have as well for these areas. And along with the surveys that we did, that Adrian just talked about, and looking at the differential pay and all that kind of stuff, utilizing certified nurse midwives was one of the things that really came out and really shown in all of our conversations. It's utilizing them, having, in some ways, possibly having certified nurse midwives go out into these communities that are very rural and having them do clinics and things like that as well, and giving those people that are in those areas the opportunity to go and see a certified nurse midwife. And so one of the things that came out of this is that the midwifery school here at Emory University is really looking to expand their nurse midwifery program, certified nurse midwifery program, and so they're actually looking to extend into Augusta starting next year. And so one of the projects that we're working on right now is trying to look and see if that is something that is going to be viable, if there's going to be support in those areas for them, because one of the threads that's coming through is that we can recruit people from those areas, and we can educate them in the areas, then maybe they will stay longer and they'll be able to go back to their home communities and work there. And so right now we're in the throes of doing this survey, trying to understand if there are people out there that will support this type of program. So far there is a lot of interest and there's a lot of excitement around it. We just need to put a few more things in place to make sure that it's going to be a successful program.
The last thing that we're also working on currently, and there's a number of other things, but I think the last kind of overarching, looking more towards solutions, is I'm sure all of you have heard about a NICU level of care. You know, every particular hospital will publicize on their website, oh, we've got this amazing NICU, we've got this, that, whatever. So back in, I think, 2012, the American Academy of Pediatrics released the neonatal levels of care criteria. And up until this point, most hospitals, especially those in Georgia, they've all self-designated their own level of care. And while neonatal care is a very important part of any delivery, the other patient that you have to keep in mind is the mom. And never before, until January 2015, had there been published criteria for maternal levels of care, which were just released by APRN, which is the American Congress of Obstetricians and Gynecology, in partnership with the Society for Maternal Fetal Medicine, for the kind of high-risk perinatologist obstetricians. So now with these criteria from the AAP, the pediatricians, and from the APOD, the OBGYNs, about neonatal and maternal levels of care, one thing that we're going to try and do this year is to actually go out and decide objectively what level of care each facility in Georgia actually needs, both on the neonatal side and on the maternal side. This, while it sounds kind of like just a bunch of paperwork and rankings and this, that, whatever, it can actually be really important, because one thing we did mention is, in addition to there being an overall shortage and maldistribution of OBGYN or I should say obstetric providers in Georgia, there's also a number of labor and delivery unit closures. So over the past 20 years, there's been like 32 closures or something like that. We have a map that also demonstrates that, which, you know, some units perhaps should not be delivering these. If they're only delivering 100 or 200 a year, you know, that might not, maybe they're not providing the best care, maybe that's too expensive of a service for them to provide. But every time they close, you know, that means further driving distance for the women that live in that area. We actually did a study, one of our students did a study that showed women that have to drive more than 45 minutes to their delivery site have 1.5 times the likelihood of preterm delivery than those that drive less than 15 miles. So the idea behind doing this objective designation of maternal and neonatal levels of care is having a map that demonstrates in Georgia, of the remaining open units, where are the ones that provide the highest level of care and where are the ones that do just kind of your standard low risk pregnant woman can come in and pop out a baby, no big deal. So that as people are getting their prenatal care, if they're identified as being higher risk, they're able to be triaged and sent to the correct facility according to their risk, whether there's a neonatal anomaly or whether there's a, mom has incredibly high blood pressure that's going to need to be managed in a particular way. So this is just another way of thinking strategically, even though we have a shortage, how can we make sure that our patients are cared for in the right place when they will need that care?
Thank you. Our next question is for Senator Hufstetler. Like the Georgia Watch report, the Rural Hospital Stabilization Committee also favored fully recognizing nurse practitioner and physician assistant scope of practice to improve healthcare access across the state. From the legislative perspective, how would you describe the response to this recommendation and the political climate surrounding this issue?
Well, in the Senate and the House, I think do have two different bodies completely. And I was listening to everybody here, and I'm from a county that of 159 counties has more physicians per capita than any other county. I've got two major hospitals within 15 minutes of my house. One's a level 2 trauma. The services there are incredible, and I'm not on the front line per se, or I'm not upstream in healthcare like a lot of people sitting here are. I'm more in the operating room where there's been too often a breakdown from diabetes control, blood pressure medicine, lifestyle, particularly smoking with everything else put together that I see there. So I'm sort of shielded from some of this stuff. I wasn't asked to be on that particular committee, and I'm not sure that Medicaid expansion was a little bit off the limits for that group, so that could have something to do with it. But I think they did some great work. And I do think when I look around the nation, there are some ways I think we could modernize some of the laws with our MPs here. And with full disclosure, I've got a brother working on his MP right now, and he's kind of extremely political. He sends me articles constantly on that. But, and I'll give the hydrocodone that was talked about as an example of difference in the Senate and the House. I got the bill through the Senate a year ago because I knew come October the laws were going to change. And we do have a big prescription drug problem here. After the first year I was in the Senate, we did the bill mill legislation. The first bill mill that was shut down was in my district, Cargill, Georgia. We've had some really good results from that. Florida has shifted up to here. And so there are definitely issues there. I also had heart surgeons, vascular surgeons, orthopedic surgeons who, when I spent a lot of my day sitting in a chair doing anesthesia, they're on their feet for 10 or 12 hours, who now are complaining that they're having to go make the rounds that their PAs or their MPs were making in the past because they can't prescribe the medicine that they could have before last October. We didn't get it through the House. The chairman of the House, Sharon Cooper, of the Health Committee, would not let it be voted on last year. We got to the Senate this year, she would not let it be voted on. If it got on the floor of the House, it would pass. I am very cognizant of prescription problems. However, I did in this see some of the statistics that said there's 40 states, I'll just talk about the PAs right now, where the PAs prescribe Schedule 2s. We had actually get MAC's agreement just watered down just a hydrocodone. The MAC was okay with that. And the composite medical systems were okay. But 40 states do. Of the 10 that don't have PAs prescribing, 4 out of those 5 of the worst states with prescription problems are from those states. So I don't see that being necessarily a PA problem. It's not a doctor problem per se. It's just that you've got a few bad apples in any profession, and you've got to regulate them. So we certainly need, when somebody has a kidney stone in a rural area, we don't need to be giving them Tylenol. They need some relief, and we need to modernize those laws. I think we can look at things you know, with NPs with a broader scope of practice. We certainly need more family physicians out there. We've got the legislation to do that. The telemedicine was talked about, and I think that's continuing to be a growing opportunity where people can be helped on that. And the other thing is the ability of these small hospitals to negotiate with insurance companies and get a reasonable rate. Even with the rate, they and Blue Cross didn't come to an agreement until the last week of our session. I had started a bill, really just sort of as a message bill. Sometimes you do that sometimes, to say, let's go to binding arbitration. Both of y'all have to pick an arbitrator, those two pick a third, and look at it and see, because if a gallbladder is taken out in Piedmont versus Brady, one is it drastically different in price. And we, before it was over, I got through the insurance committee and got through the whole Senate. I really wasn't even planning on going that far with it. I was just trying to encourage them to come to an agreement. Well, they did come to an agreement, which was good, but they, that's great. I mean, and they've got the Bernie markets, another thing that's been going back. You get these small rural hospitals, they don't have that sort of plan, and their compensation can often be too low. And it's not that, you know, in some cases they don't have enough patients, but in a lot of cases they've got enough patients. They've either got too low of compensation, and then the bigger problem is too many people that don't have insurance. We are, I know, 5th or 6th, I think, percentage-wise in the nation of uninsured patients. If you look at number of people, we're 2nd or 3rd right now. It's a big problem. And I had looked at the data of the states that have expanded Medicaid. And, you know, it's not a Medicaid's not a perfect program, and I've always said I wouldn't vote for it if it was done in Washington. But when you look at the data, the hospitals there are in the black in those states. My own company that our group provides anesthesia for has seen a 2% drop in uninsured in states that haven't expanded Medicaid. They've seen a 48% drop in states that have expanded Medicaid. But if you take some of these hospitals and say, okay, half of your uninsured are going to go away, you're going to get paid for them, it would be a huge difference for these hospitals. We need to look at that, as well as the fact that when you look at the states that have expanded it. One example would be that the diagnosis of diabetes has gone up 23% in those states. We're catching those things upstream that should be caught before, you know, I'm seeing a disaster in the operating room, but I'm seeing from that. So the telemedicine, I agree with, you know, the modernizing of the laws, but we certainly need to help these people out with the uninsured population and with the level of compensation. I'm not sure what the answer is on compensation, but it's just the prices are just all over the place in this state. And who's got the most clout gets paid, and who doesn't get paid.
Thank you. Our next question I'd like to open up to anyone on the panel to respond to, and that is, how would you describe the collaboration that's currently occurring between primary care providers in practice, physician assistants, nurse practitioners, and physicians? And how does this dynamic, our respective roles, and healthcare access change if we were to better utilize all members of our healthcare team?
I was kind of a living example like Grady. Grady had no money, no funds, but had a big sickle population. Sickle cell is one of the most costly diseases on the planet. We do some analysis as a high admission rate, readmission, high morbidity, high mortality. And when you had one physician who knew anything about it, a team of 6 PANPs and trained them, said, you be my eyes, ears, nose, and you take care of these and I'll be your backup. So he was on 24-hour call, but we didn't abuse him. But basically, we got to manage the patient 24/7 in a collaborative effort. We had social workers at our backup, a psychiatric nurse specialist. We had PAs and NPs on the front line. And for 25 years, we kept the patient out of the hospital. We got them well. They didn't need to be admitted. They were feeling better. They got seen within 10 minutes. I can't get seen in 10 minutes at any ER in this city. With IVs going and aggressive pain management, and the patients did better. It basically saved the state $15 million a year for their little investment of $3 million a year. And that was a medical home for that specific population. So it was a microcosm within Grady where there was a medical home, team-based care, and it worked. Still working.
I'll just tag on to that too, because I think the patient-centered medical home is really the way to do this. I think that we need, when I was in medical school, all of my first year classes were taken with the PA students and nurse practitioner students. I mean, so I had my two roommates were nurse practitioner students and PA students. So, you know, we got to collaborate then. But I think we need to do more collaborating and have training together. I think if we could, you know, and we also need, the thing that's missing, we need to teach our preceptors how to precept. Now that we've got over 300 providers in the state that are recognized patient-centered medical home providers, we need to come up with a curriculum on how to teach a nurse practitioner student, a PA student, and medical resident on how to function in that kind of team-based care. That team-based care is tremendously successful, and everybody practices at the top of their license, and everybody has a role to play. But I think we need to help the preceptors know how to do that.
If I could add on to that, I certainly agree with the medical home concept. When you look at the cost of somebody in one of our inpatient mental hospitals, which now must have been shut down, around $250,000 a year. Atlanta jail, $60,000. The state's more efficient, I guess, in the prison system. The cost is only about $28,000, but we've certainly seen around the country medical homes being able to take care of these people for $10,000 or $15,000. So it's at the low end of the cost, but it's at the high end of quality of care, coordinating their care. And of course, there's the federal government has seen the wisdom in that and had programs in place that would pay 80% of the cost for 2 years to get these things started. And Georgia certainly needs to take advantage of that. I think that's the way to be the most efficient quality care that we can do. I agree with both of them on that.
And I'll add on to that. I think we have a great deal of very effective collaboration that goes on at the actual practice level. I have a marvelous relationship with physicians I work with, as do most of my APRN colleagues. For all of the allied health professionals to contribute to a patient's care, the healthcare home model, the accountable care organization model as it evolves, can create a tremendous amount of opportunities for patients to receive care from multiple providers. In Georgia, all of those allied health providers can work to the top of their license as long as there's a physician on site. We have to work at the level where folks can work up to the top of their license when physicians are on site.
Thank you. And I guess building from that question, for those of us who are students and are about to begin our practices, and for those that may be in practice now, what recommendations would you have for us to help take these really positive collaborative relationships that are occurring in our practice settings and in the patient-centered medical homes, and I guess take them to a higher level, whether that be legislatively or in collaboration between our professional organizations, to help eliminate the barriers that do exist and foster better collaboration and optimize the delivery of healthcare in Georgia?
Well, I'll speak a little bit on that in a couple areas. One is, I think too often people in medicine get in their own little tunnel vision of what they're doing and forget the big picture, and that's something that's important. You can get out there and you can be frustrated, and all of a sudden, you know, you're just up here with alligators and not realizing the bigger picture, and so try to keep that perspective if you can. And obviously get involved with the legislature if you can. I mean, you know, we've got 56 senators, 180 House members. You could probably count on your fingers the people who truly understand healthcare in the legislature, and sometimes when they make a decision I don't agree with, it may not be because they're a bad person, it's because they just don't understand. It's part of our job and my job to make them understand some of these issues. And I will say that some of those that weren't in healthcare, that were part of that rules regulation committee, have changed their attitude on a lot of things, and were helpful in some things that we got in place. And if you're talking with your legislatures, try to do it ahead of the session. I mean, the session is just incredibly busy. They're running us from place to place. Most of the bills have been written before the session starts. They've got the time then. I know everybody wants to hit them up there at Capitol, but try to get a relationship ahead of time and have a look at some things. Maybe get somebody that would think, yeah, that's a good idea. Let's pre-file that, put it out there, and let it be up for discussion. Those are some of the suggestions I would have.
I would also argue that you don't have to wait till you're about to graduate. I mean, GMERG, our whole organization has been with students. I think HealthStat is similar to us. I mean, this is such a great thing that you guys have going on with the collaboration of students, getting started early, getting, understanding not only your own profession, but students from other professions and bringing diverse perspectives together. For instance, to have a panel like this and several of the other events that you've had, GMERG wouldn't be who we were. I mean, we have students, we have med students, public health students, nursing students. I mean, everybody brings unique insight because they come from a different background, even if they're not a provider yet or a public health professional yet. The things that you're learning in the classroom, you might add something that someone from the other side of the table would have never thought of. So I encourage you guys to all stay involved in HealthStat and to find other ways to contribute, even if you're not about to graduate.
And I would just add to that too, that the Georgia Academy of Family Physicians is very, very active and interested in having medical students involved in our organization, even if you're not sure what specialty you want to go into yet. In fact, we have 3 board members that are medical students, and 3 residents on our board that are residents. So we really encourage involvement, and I think it's going to be critical that you participate and advocate. And I also, as you go out to residency, learn about the patient-centered medical home model. Ask your director for a rotation or a preceptorship in a patient-centered medical home. That's, I think, the best way to learn how to be in a collaborative team. And then I think work with your nurse practitioner colleagues and your PA colleagues. And you'll kind of learn on how to work as a team and be successful.
And I'll add to that. I think both policymakers and consumers about who all the healthcare professionals are and what we are all trying to do. I think there are a great deal of lack of knowledge and misperceptions. In the legislature, we have about 30% turnover of legislators every 2-year election cycle. And
It's my turn now.
the last couple of years, it's been pretty high. We have a citizen legislature. The vast majority of our legislators do not have any background in healthcare, yet they're responsible for writing the laws and regulations. So there's a great need to educate both consumers and policymakers and ourselves, and be willing to sit down and talk between the multiple different professional organizations about just where can we find areas where we can move forward in agreement. There are going to be areas where there's going to be some areas of disagreement that our status quo is not acceptable, and there's got to be ways that we can find a way to collaborate and have a path forward. The other thing we need, and Dr. Hoffman alluded to this, Georgia has a paucity of real data about this data that I showed from the American Association of Nurse Practitioners that showed supply of nurse practitioners by congressional district. I agree that it has limitations, but that's the only data. We don't have any Georgia-specific data that says where our advanced practice nurses or our physician's assistants actually practice. And we don't have good data. Now we do have an infant prescription drug registry program, but it also has its limitations and it hasn't been fully utilized. So we're missing key pieces of data. We're also missing economic data. What is the embedded cost of some of our healthcare regulatory and statutory environment? What are some of the real costs, not in just patient access, but in the administrative workarounds and runarounds and processes that have to happen to get patient care to happen around some of our regulatory issues. And again, working together and educating nurse practitioners, PAs, other physicians, other allied health professionals together and building those understanding of each other's professions, I agree is critical, because we're all in this together, and we're all gonna sink or swim together, and more importantly, all of our patients are gonna sink or swim together.
Thank you. I'd now like to open it up to the audience. I'm sure you all have burning questions, so we'd love to hear them.
I first want to say that my son was born Roman. Right. And Floyd.
Boy, I was born there too.
There's a group that is passing around $30 bills. And that's the Voices for Prevention group. And basically saying that for every dollar that we put into prevention with drug abuse, we can save $30. And I think that's very important. Now, some of you have mentioned smoking and the cost of that. And that's, you know, fantastic amount of money. As I understand from the Campaign for Tobacco-Free Kids, it's over $2.2 billion a year to treat illnesses here in Georgia. And 530 million of that is through our money, state, you know, state
Medicaid.
Medicaid.
It's 542 million.
Yeah. Well, it's gone up a little bit. The thing is, we bring in about, I think it's 240 million. So
We bring in 214.2 million, so it's even worse than the number.
So it's at least over $300 million gap between the cigarette tax and the outgo just for Medicaid.
And that's just the direct cost.
Right. Yes.
Not indirect. I think the CDC's numbers were 3.18 billion. Total direct cost.
And we had probably a bill coming through the process to increase the cigarette tax $1, $1.25, whatever it was, and that didn't make it this time either, did it?
No, and I was the one that got the fiscal note done in January, and the reason I did that was because I knew the transportation discussion was coming up. That was going to be some battles, and I was trying to use that as a way, and there were a couple people in this room that were helpful in that process. They were trying to take that opportunity. Georgia is 48th in the nation in tobacco tax. We're lower than Kentucky and North Carolina tobacco states. We have a huge cost there, and just to bring it to national average was going to bring in more money than they were bringing in through this transportation. So I was trying to use that as an alternative. My motive was the other states' data say that smoking consumption would go down 10% if we did that, and youth smoking would go down by 14%. That's really where we've got to get them this age 21. There is a lot of lobbyist support from convenience stores, Philip Morris, that have got some people to make some commitments. That's really the problem. Is the data is so clear that and I want to help these people stop smoking. I also don't want to subsidize them. I mean, when somebody goes to one of these convenience stores and buys a pack of cigarettes, it's costing us about $3. And I hope that we will look at that. Alabama is looking at a $1.25 tax right now. They're still in session. And Bobby Jindal is proposing in Louisiana a tobacco tax increase, and believe it or not, Grover Norquist is in favor of it. I've never heard that in favor of
the tax?
I'm shocked.
Yeah. So that I don't understand that either, but that's what he says. He's for it there. So I do hope we can have more discussions. I've been told from some Washington people that we'll get a lot more support in this next session. And I mean, tobacco costs, and I know most people know this, but you know, it's our #1 health problem. It costs more than AIDS and heroin and alcohol and cocaine, and car wrecks, and murders, and fires, and all that stuff put together.
Yes.
If we want to make a big impact on our healthcare costs, we can do it. Now, even if that money went in the budget and didn't go necessarily toward healthcare, I knew we would see millions in savings in healthcare over the long haul. And the data said that if we did that, we would stop 28,000 of our current youth from dying early from tobacco-related diseases. So The legislature doesn't do a lot of things necessarily on data. That is less than science.
Well, I'm hoping that they will get around to designating some of that money to go, cigarette tax to go in to pay for Medicaid or whatever. And,
But my argument would be we don't need any money to pay for Medicaid expansion because the government was going to pay 100% for 3 years down to 94%. If you look at the data from Dr. Custer, the jobs you would create, the savings you would generate. Jan Brewer, Tea Party favorite in Arizona, put it in, and you can look on her website when she was governor. There's a new governor, and it says this will not cost the state of Arizona 1 penny, and it hasn't. So it doesn't cost us billions of dollars. It doesn't cost anything. It does cost us money in federal taxes and federal deficit. I won't disagree with that. The state of Georgia.
Will we have to take an election year next year?
Well, there's some positive things going on right now. Yeah. There's some things happening here. I think we've got some traction right now.
Great.
Can I just get a small thing about when we're talking about tobacco prevention on the pediatrics perspective too, just to let you all know, because I know most of you are healthcare students. The CDC just released some alarming data in the last couple of days that showed that e-cigarette use among children and youth is exploding and has exceeded traditional cigarette use. And nicotine is an addictive drug. It is a gateway to other addictions. It helps to pre-program the developing adolescent brain to be more prone to addiction. And it is an alarming trend. So we need to look at how the FDA has failed to act on some regulations they propose, some deeming regulations they propose to better regulate e-cigarettes. But they're being marketed to youth. The flavors are like gummy bear, watermelon, everything else. Vape couture, this is not your mother's cigarette. So we've got a tremendous public health problem in the making and addicting a new generation of children to novel tobacco products with the healthcare consequences coming at us in the future.
Thank you.
Some additional questions?
I had a question just to clarify from my own understanding. I know that nurse practitioners, particularly when they have prescriptive authority, there can only be a 1-to-4 ratio between the physician and the number of nurse practitioners that they supervise. And the signatory requirements often require a lot of on-site supervision, but there are times when nurse practitioners are operating in a facility independent from the physician. I'm sure that creates a lot of complications in our current regulatory framework. But do PAs ever, are they always on site with the physician in the same office, or are they ever 50 miles away at another practice site?
By law, they have to work in the same practice as the physician. Physician doesn't have to be physically there. They can be in telecommunication. But as long as it's in the purview of the physician's office and not an independent outside of the physician's practice, we can't set up a shop and just go rogue. It's got to be the physician does see patients in that office, but they may be in office A while the PA is in office B, and they cross cover each other. So they
But it can be pretty far away.
Yeah, absolutely. And it's only a phone call, text, or email way.
So, okay, focusing on Atlanta for a second. What's been happening is, and I've heard people say this, next 5 or 10 years in Atlanta, basically we're becoming centralized in terms of healthcare delivery. So Piedmont, Kaiser, Emory, they're soaking up these smaller hospitals. And there's people that think those are going to be 3 or 4 conglomerates within Metro. So it's not unreasonable. Let's say that happens in 10 years. And if that doesn't happen in Atlanta, that spells bad news outside of Atlanta. And let's say a future happens where what ends up, it's just satellite locations of these 4 reaching out, like arms into rural communities, and all these rural community hospitals are either affiliated with faculty or just work for them or owned by them. I don't know. Is that a good thing? Number one. And if this does happen, because if it happens in Atlanta, I can see that happening elsewhere, especially with local community hospitals closing. What would be the advantages, or what could something that's so centralized be? What could be an advantage of that?
Well, the spoken hub method is one of the things that they're looking at with the Rural Stabilization Committee. You know, from a good standpoint, it could be that it gives that smaller hospitals some depth of expertise to call on. Get things that are too complicated. It could give them better purchasing power, negotiating power for purchases, and better negotiating rates with insurance companies. So it could be a good thing. You know, you do worry about if it gets too concentrated in too small a hand, whether it's the cell phones or cable TV or whatever. Sometimes it gets so where there's not enough players in the game, then competition is always good. But I don't think that it's necessary to be bad either. I think it could help some rural hospitals hang around by having the depth of help from some of these bigger facilities.
Well, to your point, Senator, I think that things like telehealth would be more easy to do. You know, you have the centralized hospital with a finger out here, an arm out here that could easily have telehealth set up easily and access to subspecialists. The other thing is more and more physicians are employed. More than half physicians now are employed. So I think it could address some of that lifestyle issue that I talked about earlier, where physicians out in rural areas can make more money necessarily and have a nicer lifestyle for people to share call with, access to telehealth, those kinds of those lifestyle issues that will help doctors want to stay there.
Play devil's advocate, specifically from the maternal and infant aspects. I think the upside is, of course, higher level of service provision at a particular hospital, but the downside specifically, this is not necessarily translatable to family medicine or any other specialty, but a particular obstetric provider cannot be, their office where they see patients cannot be more than, 20 miles at most from the place where they deliver babies. So if you centralize all of these rural hospitals, including obstetric services, then that means it's very difficult for obstetricians or their midwives to get out into the community to provide the prenatal care. Even if those women have to drive great distance for delivery, that's fine, but you can't have a physician being 50 miles away when they have to get there to deliver those patients. So it's challenging from our perspective.
That's one of the reasons we stopped OB when I was in the mountains of North Carolina, because it was 20 miles to the hospital. The hospital has since closed, but we couldn't drop everything out of the hospital.
Can I add just one thing to that? I think you see too a possibility of something being worked out as a collision between the tendency for hospitals and hospital systems to merge and become larger conglomerate, and the insurance experience of narrower and narrower provider networks. And if you've got hospitals, and merged hospital systems being huge provider networks, but insurance companies only recognizing narrow provider networks, I think that's going to be an opportunity for some possible conflict that might complicate coverage for individuals. And I think that's an issue that needs to be worked out from a medical, economic, and access perspective.
You mentioned at conferences about restrictions on being able to prescribe certain class 2 before we can allow more people to prescribe for them. I know you're not the be-all end-all, but what would you do? What restrictions would you put on for NPs, and physicians to help control that? And
that's a great question. I don't pretend to have all the answers. It's a tough problem. But one of the things we talked about when we were working with the senator on the PA prescribing bill was putting something in place that may have limited quantity, have quantity limits. 5 days of Lortab or 5 days of something like 10 days, we could live with, as under our current structure. I think because we've all heard horror stories, and I don't mean to be anecdotal, but grandma gets 30 days worth of hydrocodone. She takes 4 of them, and it sits in her medicine cabinet, and the nephew finds it when he's there visiting. So that's what we want to avoid. And I'm not pointing fingers at PAs or advanced practitioners that don't do that. Doctors do that too. So, but I think having some quantity limits, I think, would allow us to be able to support some of these changes.
As a follow-up to that, is there any evidence, you had mentioned something slightly different in terms of
evidence for expanding providers being able to prescribe, but is there any evidence to support the idea that by expanding providers' abilities to prescribe medications and PPCNP specifically, that expansion does actually negatively impact prescription drug abuse? Or is that just?
I don't think that research has been done. It's a great question. Certainly, I think one of the reasons we have some hesitation about doing that just blanketly is that, at least intuitively, you think that having more people prescribing without limits could increase that, and I don't know the answer to that.
Well, I can tell you the experience in other states, and I think that's one of the areas of the country. We have a lot of concerns that are, as Dr. Hoffman said, are intuitive concerns. And about increased utilization for diagnostic procedures or about prescription drugs. And those intuitive concerns really are not borne out by evidence. There is absolutely no evidence anywhere in the United States of America that shows that reducing barriers to nurse practitioners and other advanced practice nurses being in practice to the top of their license creates any risk for patient care. The PA and APRN regulation from state to state is slightly different. There are only 9 states in the country where APRNs cannot prescribe Schedule II medications. And in some of those states, that Schedule II authority has been in place for 40 years. And in some of those states, they have very robust prescription drug monitoring programs where you can get from both ends. You can target problematic prescribing patterns by providers as well as problematic utilization, drug-seeking behavior by patients. And there has never been an increase in malpractice insurance rates in those states. There's not been an increase in complaints to nursing boards for prescriber misbehavior. And in no state in which Schedule II authority has been granted has it ever been rescinded.
Georgia has lacked a lot of data, and that is one of the things that we have done recently is we set up a database that's going to give us a lot more knowledge of specifically where it's being prescribed at, and I think that's going to be helpful. There is some data that would say a PA or NP typically would prescribe for a short period of time on average, and I think some of that is, and I see it with the surgeons I work with, they're incredibly busy. They work so hard, and they may, think I'm going to give them this prescription for this amount of time, whereas the PA may give it for a little bit less time. Say I'll see them again. They've got maybe a little bit more time, but the database is going to be helpful. I mean, we do good things in the legislature. We feel sometimes afterwards, well, did we get anything good done? Because we think of all we did get done. Well, the database has been good. The bill mill legislation is working. We got Grady and Blue Cross to come to an agreement. I think we sort of pushed them into it. That's good. Since the governor signs it, we'll have sales tax exemption for care clinics. That's going to be a good thing. There may be more alternatives out there when the dust settles about expanding Medicaid that maybe people know right now, but we'll wait on that for a little bit later time. But there's positive things that have happened in our legislature, but it's hard work staying on top of it because there's always people that want to do things that aren't in the best interest of the consumer.
I think we need the bottom line for all of us is we need more research on these kinds of issues. I think Beth in her paper actually referred to some studies that went on health affairs that actually shows that there wasn't a significant difference between advanced practice nurses and primary care doctors in terms of some outcomes. A lot of those studies are just done on a couple of diagnoses, like otitis media, things like that. So I think we need more of that. But I think to draw a blanket conclusion that there will forever always be no difference, I think is a little premature until we understand it better.
I think we can take one more question.
Okay, so in a rural community, it's not just health we're talking about. It's less likely to be cultural aspect, less likely to be a violin player, great, because I don't have that support network. I'm less likely to be a tennis player, sport athlete. Less likely for education point of view. My education is a lot worse. And my point is there, and we just kind of accept those things. I mean, there's not a huge movement towards fixing any of those because that's just how it is. But do you see a point when, this is not a popular thing to say, but where we just, maybe we implicitly already say this by our policies, if you live in a rural community, your health care is going to be worse. Like that just might be an implicit thing that happens. We don't have the funding to take care of the problem. And then
that's a tough one. I don't think we ever want to get to the point where we have a two-tiered healthcare system. If you're lucky enough to live in an urban area, you get good health care. If you're not, I think we need to approach and be creative and think outside of the box in terms of how do we get physicians and nurse practitioners, advanced practice nurses, and PAs to go to those areas, deal with those lifestyle issues. And maybe that's providing salary supplements to residents so they want to go there. Starting the loan repayment program while you're a resident, if you promise to go to a, not wait until you get into practice, which is what the current is. So, start it earlier to get people to go there. I think that we need to approach the heart of the problem, not just wash your hands and say, well, it's just never going to be the same. I think there are ways.
I think you hit the nail on the head, and I think access to healthcare in rural communities is becoming not just a healthcare issue, it's becoming an economic development issue. Just as companies don't want to build and bring employees into areas where there's not a good education system, they also don't want to bring their employees into areas where there is lack of access to healthcare. And that's why I think you have a wider community of consumers and businesses, as well as the healthcare community and the legislature, being very concerned about what we can do to increase access to care in rural areas. And I think we have to look at all options, including the option of modernizing our practice laws so that we're utilizing more healthcare practitioners to the fullest extent. And there was a report in 2012, it's Understanding Advanced Practice Nurse Distribution in Urban and Rural Areas in the United States, and its National Provider Identification Effort. This was a collaborative effort from the Rural Health Research Center at the University of Washington. And it found that states with fewer barriers to APN practice and care of nurse practitioners were more likely to work in rural areas. So that's one way we can get more non-physician providers in our rural areas. The other thing that we need to look at, and there's a wide way between the full implementation of the APRN consensus model, which by the way is not independent practice. Independent practice brings it this discussion like Allan said, of going rogue and setting up your own practice. We are all collaborative environment, but full practice authority for APRNs just means removing unnecessary administrative and statutory contractual barriers. The green states are where states have full practice authority. The yellow states are some lesser, but still collaborative environment, less looser. The red states, of which Georgia is one, is an extremely restrictive environment. And if you notice, some of our border states, especially in Alabama, are not. And our healthcare workforce is mobile. I have found working with students in areas, a lot of students that were educated in Georgia are choosing not to stay in Georgia. They're choosing to go in other places because they are being educated with the skills necessary to work in any of the 50 states in the United States. And if they stay in Georgia, they won't be able to utilize all those hard-earned and hard-won skills. So many of our students are not staying in, not only are not staying, going to rural areas, they're not staying in Georgia. They're not places where they practice environments.
And one quick point I'm sure Sandra's going to work on next session. We have succeeded in increasing the numbers of advanced practice nurse students, and PA students, and medical students dramatically. What has now happened, though, we don't have enough graduate medical education slots, i.e. residency slots, in this state. Well, we've already added 400. We are, in another year or two, we will be graduating more students than we have places to put them. And as we've heard tonight, if we don't have the graduate medical education slots, people aren't going to stay in Georgia.
We're adding more slots, more hospitals around.
Right.
Wonderful. Thank you so much. Please join me in thanking our really appreciate you sharing your Monday evening with us and all of your expertise to contribute to this discussion. We thank our audience for participating and for attending tonight. If you have any questions that are still unanswered, please let us know. We'll do our best to get them answered. Also send out a survey to get your feedback on this event if you'd like to see things like this again in the future. And before we go, we do have small tokens of appreciation for each of our panelists, little tumblers. But you know, you can share. Thank you so much. And then one more round of applause.